academic sessions. Dr. Vineet, are we going ahead with academic session or somebody else also having a inaugural address as well?
Yes, we are. If we are ready, we can start the session.
Okay, fine. In that case, once again, I would like to congratulate all of you for being a part of this conference. I hope this will be a wonderful knowledge feeds for all of you. So we will start with our today's session. Dr. Vineet, over to Dr. Vineet.
Thank you. For the session, we have Chairperson Dr. A.K. Singh sir, Clinical Cardiologist at Devkamal Hospital, Ranchi. Dr. Santosh Gupta, Clinical Cardiologist at Jamshedpur. Dr. Rajkumar G. Nadkinamani, he is Clinical Cardiologist at Badr Al Sama Hospital, Oman. Also, he is President of Karnataka IACC Chapter and Joint Secretary IACC. I would also request Dr. Santosh B, Clinical Cardiologist at Kannur, and share the session. Over to Dr. A.K. Singh sir to introduce our chairperson. Dr. A.K. Singh sir, please. Dr. A.K. Singh sir.
Oh, good morning, sir.
Sir, you have to introduce Dr. Rajesh Rajan. His slide is on your screen.
Good morning. Welcome all to IACC conference online. Our chairman is Dr. Rajesh Rajan. He is MD, PhD, FRCP, Edinburgh. He is cardiologist, Shoaib Al Ahmad Cardiac Center, Al Amiri Hospital, Kuwait. He is Board of Governors of IACC, Managing Editor of our annual paper, Annal of Clinical Cardiology, and is President of Association of MD Physicians. In charge of various clinical research registry in heart failure, authorized several, he had authored several publications, and he is in more than 50 cardiology journal editorial board. And he is our first president, very active, very supportive, and we wish best of luck and for future. Thank you.
Thank you, Dr. A.K. Singh sir. As this is a chairman's address, we request to kindly accept a medallion for the chairman's address along with this certificate. With that, I request our chairman to start the session.
Thank you very much, Dr. Vineet and Dr. A.K. Singh.
Authorized start the session.
Today, we're going to discuss, to start with, COVID-19 cardiac complications. I'm pretty sure that we have thousands of articles came on this topic, and day by day, the information we have, it's keep on changing. It's very important to know the cardiac complications in COVID-19 patients for every physician, so that you will not miss a cardiac case, as the mortality is much, much higher compared to patients without cardiac complications. So SARS-CoV-2 virus can directly injure the myocardium. This was a question for most of the physicians. I can tell you, patients with myocardial injury found to have fourfold increased risk of mortality. Recently, data from Germany shows 60% of the patients experienced myocardial inflammation independent of pre-existing conditions. This data from Germany, this myocardial inflammation was confirmed by cardiac magnetic resonance imaging. And another study which 16.7% developed arrhythmia. Myocardial injury in confirmed COVID-19 was reported as 19.7 in another study. Mortality among the patients with myocardial injury was 51.2%, compared with 4.5% among those without cardiac injury. 59% of known survivors had myocardial injury, and myocardial injury is an independent predictor of in-hospital mortality. Myocardial injury was defined as blood levels of high sensitivity troponin above the 99th percentile upper image, regardless of new abnormalities in the electrocardiography and echocardiography. COVID-19 studies have shown that myocardial injury, irrespective of the nature of the troponin elevation, is associated with higher risk of death and arrhythmias. In another study conducted in Wuhan, cardiac conditions including heart failure contributed to 40% of the mortality, either acting alone or in conjunction with respiratory failure. Following careful evaluation, patients with cardiac troponin increase indicative of myocardial injury, including those with COVID-19, should be classified into three. It is chronic myocardial injury, acute non-ischemic myocardial injury, and acute myocardial infarction. Chronic myocardial injury, a term, applies to those with chronic stable troponin increases can be frequently encountered in patients with COVID-19, given the older age and higher prevalence of chronic vascular conditions observed in these patients. While the term acute non-ischemic myocardial injury applies to patients with dynamic rise and falling in cardiac troponin concentration without clinical evidence of myocardial ischemia. Probably predominant mechanisms of cardiac troponin increase in patients with COVID-19. And you all know the definition of acute myocardial infarction. The mechanism of acute myocardial injury, the pathobiology of coronavirus infection involves SARS-CoV-2 binding to the host receptor ACE2 to mediate entry into cells. As you all know that ACE2 is expressed in lungs, heart and vessels. Is a key member of renin-angiotensin system and important in the pathophysiology of CVD. Cardiovascular disease associated with COVID-19 likely to involve dysregulation of RAS ACE2 system due to SARS-CoV-2 infection and due to comorbidities such as hypertension. CVD may be primary phenomenon in COVID-19, but may be secondary to acute lung injury, which leads to increased cardiac workload, potentially problematic in patients with pre-existing heart failure. You all know that cytokine release storm in COVID-19 is devastating. It originating from the imbalance of T-cell activation with dysregulated interleukin-6 and other cytokine may contribute to CVD in COVID-19. Interleukin-6 targeting is being tested therapeutically also. Immune system activation along with the Immunometabolic alteration may result in plaque instability, contributing to the development of acute coronary events. Poor prognosis in acute coronary syndrome in COVID-19. In patients with acute coronary syndrome, cardiac functional reserve can be reduced owing to the myocardial ischemia or necrosis. Cardiac insufficiency is more likely to occur, leading to a sudden deterioration of these patients. Underlying heart disease with cardiac insufficiency, SARS-CoV-2 infection might act as a precipitating factor to worsen the condition and lead to increased mortality. Major cardiac complications in COVID-19 can be acute coronary syndrome, which usually varies from 7 to 27.8%. Another one is myocarditis, possibility of direct viral infection of myocardium and vascular endothelium. Other complications like pericardial effusion, arrhythmias, cardiogenic shock, and death. We know that cytosolic, extracorporeal cytokine absorber, and plasmapheresis to treat cytokine storm is a possible option. Pulmonary artery catheter is an ideal for guiding the treatment, as shock mostly a mixed type of both cardiogenic and vasodilator. Convalescent plasma containing neutralizing antibody was seen effective in critically ill COVID-19 with ARDS. There are so many treatment-related risks. The use of antiviral drugs and hydroxychloroquine should be monitored. Many antiviral drugs can cause cardiac insufficiency and arrhythmias. Arrhythmias mainly induced by hydroxychloroquine is well. The risk of cardiac toxicity must be closely monitored. Hydroxychloroquine-induced restrictive cardiomyopathy also was recently reported. So, regarding the treatment for myocardial injury in COVID-19, there is no specific therapies exist for myocardial injury due to COVID-19. For patients with COVID-19, the cardiac troponin increases. Usually, clinical practice guidelines applies to those with type 1 myocardial infarction, heart failure, or cardiomyopathy and arrhythmias. Individualized care for each condition is required in those with acute non-ischemic myocardial injury. Most cases of type 2 myocardial injury and acute and chronic myocardial injury can be managed conservatively. Anticoagulation. Heparin has been implicated in binding COVID-19 spike protein as well as down-regulating interleukin-6, which has been shown to be elevated in COVID-19 patients. Unfractionated heparin or low molecular weight heparin remains the best choice of anticoagulation for admitted patients. It is possible that patient may even require to continue the anticoagulation for a certain period even after discharge. It's very important. Recently, one of my colleagues, who is an internal medicine consultant working in Al-Amiri Hospital, Kuwait, day before yesterday, he passed away because of acute myocardial infarction and cardiogenic shock. He was treated with the diagnosis of COVID-19. He was on ventilator for so many days, and he was discharged stable, and suddenly, all of a sudden, he had a myocardial infarction. So it is advised to continue anticoagulation, even if there is no guidelines how long to continue anticoagulation in high-risk COVID-19 patients. So, recommendation, I have 7 recommendations for a treating physician. The highest priority is prevention and control of transmission. Patients should be assessed for both COVID-19 and cardiovascular issues. If you are treating a COVID-19 patient, always to advise to do a bedside echo and a cardiac troponin with, or perform imaging studies in patients with suspected or confirmed COVID-19 only if the management is likely to be impacted by imaging results. Use proper PPEs while performing imaging studies, especially echocardiography. Always rule out acute coronary syndrome. Type 2 myocardial infarctions are common in the critically ill when ischemia is present. Early detection of myocardial injury in COVID-19 patients can reduce mortality. Addition to routine clinical evaluation, the standardized measurement of cardiac troponin for the detection of myocardial injury, along with the other inflammatory markers like C-reactive protein, ferritin, interleukin-6, and procalcitonin, and thrombotic markers like D-dimer, may facilitate understanding whether the patient is in stage 1, that is early infection, stage 2, that is pulmonary phase, stage 3, hyperinflammatory phase. So always ask for this inflammatory and thrombotic markers along with cardiac troponin so that you can stage the patient and treat accordingly. Further, as continuous prognostic marker, the initial troponin measurement may help triage patient, and subsequent serial troponin measurement may help identify the lower risk patient with the stable concentration or the higher risk patients with increasing pattern. Later may be needed additional evaluations. Thank you very much. Let's fight and save our nation. Thank you.
Request our chairpersons to have question answer session, if any, or comment. Dr. Rajkumar, Dr. A.K. Singh.
Yes, sir.
Dr. Rajkumar, Dr. A.K. Singh.
Good morning to all.
Comments?
Yes, that was a very informative talk.
Session. We would like to have comment from Dr. Rajkumar and Dr. A.K. Singh, sir. Dr. Santosh B, sir.
Good morning, sir. Thank you, Rajan, sir. It was nice information. Many things I was not aware. Most probably others have also have been benefited. Thank you.
Thank you very much.
Yeah, good morning, Rajesh, Unique and all. It's a nice presentation. Thank you. Thank you.
I request our chairpersons to kindly accept the certificate on behalf of being faculty at CARDIOZONE 2020, Dr. A.K. Singh, sir, Dr. Santosh Gupta, Dr. Rajkumar GN, and Dr. Santosh B. Thank you so much, our chairpersons. Thank you so much, Dr. Rajesh Rajan, chairperson. We would like to
Thank you,
have
sir.
your presence for the conference throughout the day.